role of treatment is palliation and life prolongation. And according to the type of tumor, most common is the clear cell adenocarcinoma. Most of the patients come with this. Other rare types are there like papillary chromophobe or sarcomatoid variety, or sometimes rare tumors like lymphoma and like that.
Right, right.
But if you per se say a renal cell carcinoma, we mention actually we mean is the clear cell adenocarcinoma. All the data, treatment data is based on that. Other tumors are relatively rare.
Right, right. Okay. All right. And Dr. Anita, welcome. Thank you for joining. What are the stages that people should be aware of in terms of, the kidney cancer?
Thanks, Aparna. I'm sorry I joined late. I had patience to finish.
No problem.
Okay. So yes, regarding kidney cancer, we're talking about stage. A few words for the viewers. Yes, before we go on to the stage, we need to know how we do the staging. Okay, apart from a local imaging, which can involve a CT and an MRI, we do make use of the PET scan to see how far the tumor has spread. So coming back to your question, just for a layman, if you notice stage 1, okay, it's stage 1 is a confined small tumor in the kidney, which has not involved the fascia, which has not gone out of the kidney, has involvement in renal vessels, and there is no involvement of the lymph nodes. That's why.
Right.
A little bigger in size, without, again, node involvement, venous involvement, okay, might have touched the fascia of Gerata, maybe a stage 2. Whereas, by definition, when you say stage 3, that means it's a locally advanced cancer where we might get a renal hilar node positive, ipsilateral, or might be a contralateral. The tumor is a little larger enough. It might have involved the fossa. It might start involving the surrounding structures, maybe on the right side, the liver, and the left side, the kidney, the perinephric fat, and that's the locally advanced ones, okay, which sometimes become difficult for a surgeon to take it out.
Right.
Whereas the last stage, where we are really afraid of, and that's the stage 4 cancer, where the cancer cells, any size, the tumor can be any size. Yes, nodes are positive, they go to the lymphatic vessels, and then these cancer cells to the blood, and once they get into the blood, it goes everywhere in the body, starting from the liver, the bones, the lungs. And these are some of the common sites where these small micrometastasis starts lodging in and starts developing into a bigger thing. And that's what we are very afraid of. That's the last stage of cancer, and that is stage 4. And again, Aparna, to all the viewers, yes, if you try that you don't come in the last stage, that is the stage 4. And if you are able to pick up in stage 0 stage also, and stage 1, stage 2, 3, yes, renal cell cancer is curable. We can do a lot of things with surgery and the newer modality, but stage 4, everything becomes palliation for us. That's the importance of staging.
Right, right. Thank you. Dr. Gupta, cancer treatment, and we were talking before the webinar that kidney cancer treatment has changed a lot. But if you could highlight again, what are the various treatment options, and how has the change happened over the years?
Aparna, if you see, there is a lot of changes in last 3 decades for kidney tumors treatment. When I was in Adyar Institute in Chennai, that time I always say, kidney tumor is a baby of surgeons. Because that time we thought that it's a chemo-resistant, radio-resistant tumor.
Right.
But if you see last 2 decades, we have a number of drugs available in which we have a anti-VEGFR inhibitors, we have a TKI, we have a mTOR inhibitors, we have a checkpoints inhibitors in a form of immunotherapy, or we can say biological agent we have. In 2005, once we have a first TKI, sorafenib, the picture changes. Slowly in 2006, the sunitinib come, and number of times the new drugs come. And 2022, we are talking about not only the TKI, we are talking about the biological agent. We are talking about the checkpoint inhibitors like nemolizumab, pembrolizumab, combination of a TKI plus immunotherapy.
Right.
So I can say that not it's a surgical baby. In due course of a time, it's a medical oncologist who is handling this case, even in a metastatic disease, In such a form, when people diagnosed as a case of a renal cell carcinoma with metastatic disease, people thought it's end of roads. But today we will say that we have options of treatment, not only once, we have 4 segments of treatment options: oral pills, combination of checkpoint inhibitors, or ipilimumab plus the pembrolizumab combinations or nivolumab combinations are available. So patients are having an option and a better survival even in a metastatic disease in a present era.
So, Dr. Gupta, can you just explain those combinations in layperson's term? What do those various,
Okay.
Thank you.
Means if you see in the past, we are talking about a cytokinins role. The interleukins, basically low dose versus the high dose. And in high dose, patient need a ICU care during the infusional time, complications of heart side as well as sometimes septicemia, but they have reported CR. But once the TKI developed, like sorafenib developed in 2005, this drug was available as a pills form treatment for kidney tumor in a metastatic disease, but slowly replaced by in 2006 by sunitinib, one of the drugs which has shown a very good response rate even in a metastatic disease. Toxicity have reported different from the cytotoxic drug. And slowly we talked about the mTOR inhibitors, means everolimus drug in the kidney tumors. Then bevacizumab drug as a biological agent. Then slowly, even in a TKI, we are talking about axitinib, pazopanib, cabozantinib, new drugs are available. So, not we are talking about the TKI, now we are talking about the checkpoint inhibitor, in which we are having a nebulizumab and pembrolizumab if PDL1 is positive. Then we have a single agent versus the combination. In adjuvant setting, the recent trial shows that pembrolizumab has shown a response and increased the overall survival in a specific subset of patients. But in a metastatic disease, you can talk about a role of axitinib combined with the pembrolizumab as a TKI plus checkpoint inhibitors, cabozantinib combined with the nivolumab or pembrolizumab. You have a ipilimumab combined with the pembrolizumab as an option, and in a sarcoid variety, you have a combination of the pembrolizumab combined with the other drugs. Even you can go for a rare disease like sarcoid variety chemotherapy, but the immunotherapies are options with minimum side effects. So the science has changed in last 1 decade. It's totally depend upon individual to individual patients, general condition, comorbid condition, affordability, stage of the tumor, and the precipitating factors. If patient is having a diabetes, hypertension, the reason of that. So you can basically select the drug as per the subset of a patient, depend upon histopathology and stage of the patient and financial aspect of the patient.
Okay, thank you, Dr. Gupta. Actually, we got one question, Dr. Anita, if you're there.
Yes, please.
Because we have a lot of CKD patients also who follow us. So, are patients with chronic kidney disease at greater risk of kidney cancer? Is that an issue?
Yes, I will not say like that chronic kidney disease, but then we need to know what is the chronic CKD. Is that incidentally, like how we detect myeloma in a chronic CKD, we might develop a renal cell cancer, but then a CKD might not, plus or minus, might not directly related for the development of cancer. Otherwise then we would have got a large number of renal cell cancer, seeing the volume of patients on dialysis. Exactly not.
Right. Okay. Thank you. I think that should be reassuring to our CKD patients. In terms of Dr. Jayakumar, you talked of kidney cancer being diagnosed, and I think Dr. Chatterjee also said as an incidental cancer, but is it also a secondary cancer?
Kidney cancer actually rarely produces a secondary cancer. But certain syndromes like VHL, Van Hippel-Lindau syndrome, Cowden syndrome, tuberous sclerosis, some of these has association along with, and these patients have other malignancies also. As a secondary, I don't know whether any of the panelists, is there any secondaries like? Actually,
very rarely kidney cancer can present as a metastatic disease from other organs like breast, lung, GI, but
it's
it is very rare, very
Very
rare.
rare.
I don't get a single one in my 1 year practice. I think zero
Right.
per year. It is like
Right. Okay.
I too have not.
Right. And Dr. Chatterjee, I know Dr. Gupta talked about, all of the treatment options, but if you, because everybody's highlighting the importance of early stages, what is the primary mode of treatment for early stage
early
kidney cancer?
stages, even locally advanced stages, main treatment option is surgery. Surgery,
Right.
surgery, and surgery. Timely, adequate surgery is the only option for cure. We need to get it remembered. Whatever may be the modality of surgery, it is open or laparoscopic or robotic, whatever. But main surgery is the main mode curative option. And nowadays, surgical techniques are also developing like anything. So you need to consult your surgical oncologist, have a plan for a curative surgery, and that is the main thing: early diagnosis and surgery, which is the most important curative option.
Right. And in terms of obviously, once you have kidney cancer and you're going through the treatment, often there are complications and kind of toxicities that happen due to the treatment and because of the condition itself. Dr. Gupta, can you just talk us through the potential complications of kidney cancer and the treatment?
Means I would take this thing in two ways. Means that disease-induced complications or treatment-induced complications. If kidney tumor is basically having a metastatic disease, number of times they are having a severe anemias, fatigue. Hematuria itself is basically of two types. Microscopic, you cannot see, but in microscopes you can easily see there is a RBCs. Then you can say it's a microscopic hematuria. Or there is a gross hematuria, you can see a blood stained with the blood. Is a gross hematuria in kidney tumor. Sometimes there is a edema because of the low hemoglobin as well as protein loss. Sometimes there is a pain in flanks at the kidney side, right or left, depend upon the kidney side tumor. Sometimes there is a weight loss and cachexia because of the disease and because of the treatment related reasons. Also, patient is having a loss of appetite, cachexia, and sometimes there is a hypoalbuminemia reported. Patient is having a severe depression because of the treatment related as well as disease related symptom. So number of factors are responsible for this. Means sometimes patient once treated by the doctors has some complications. Basically, it's a TKI induced or immunotherapy induced. Sometimes there is a mucositis. Sometimes there is ulceration. The hemoglobins are low. Platelets are low. They feel fatigue, so weak, loss of appetite, and sometimes basically have in a depression because of all the silent symptoms.
Right. So let's look at each of these different categories of, not categories, the complications themselves. Dr. Chatterjee, if you can talk us through, because I think one of the common effects of the treatment itself is often diarrhea and rashes, etc. So, how can these be managed? What should patients do when they are feeling these side effects?
Renal calcium pills and their side effect management is a different topic altogether. It's a long topic. I'm just going through a little bit of details. One of the complications is rash. Little bit of rash, which is tolerable and not affecting patient day-to-day life, we need to ignore because anecdotal data are there. Those who develop rash also respond well. But when the rashes are causing problem with the day-to-day activity, or there is blister formation, or there is weight ulceration, first of thing, you need to stop the medicine for few days, consulting with your doctor. And then there are drugs like double 20% urea creams, moisturizers, emollients, sometimes oral antibiotics like doxycycline, we give it. And if the rashes are persisting and severity of rashes increasing, we may actually end up decreasing the dose a bit. One step dose decrease is a dictum and very well known. Regarding diarrhea, this renal cancer pill induced diarrhea is non-infective diarrhea. We have to remember it. That is not like a gastroenteritis, some bacterial infection like that. It is not that like that. It is mainly secretory diarrhea. So first of all, again, stop the pill for 1-2 days and take a lot of water, ORS, and anti-secretory agents like loperamide, diphenhexylate, like that, which will decrease the secretion, constipating agents or anti-secretory agents, and lot of fluid and electrolyte balance to be maintained. This is the way to go forward. Sometimes we decrease the dose, but before that, we need to try the standard treatment procedures.
So when you said that ignore the rashes, is there palliative, is there like, is it okay to put a rash cream or things like that?
Yeah, you can put that. I was telling that 20% urea cream like that, you can routinely use, no problem with that. Little bit of rash will happen to every patient, not that that will make us decrease the dose or stop. But when the rash is causing problem with the day-to-day activity, or there is formation of blister or ulcer, you need to stop the medicine and take a lot of anti-rash medicines and like that.
Right. Sorry, somebody was saying something. Was it Dr.
I just wanted to ask, to Dr. Chatterjee, most of the patients come in metastatic setup, that time also, do you advocate surgery? Because you talked about the surgery. So what is the role of surgery in metastatic setting?
In today's systemic treatment standard, role of surgery in metastatic setting is mainly hematuria. If there is uncontrolled hematuria or severe pain, which we cannot control, we can go for a palliative nephrectomy, but that in survival benefit, that is not there.
Right. Dr. Anita, again, two of the complications or side effects that Dr. Gupta talked of were anemia and fatigue, right? So again, how can patients manage those issues?
You're talking about anemia, basically.
Yeah. And I guess fatigue can be because of anemia or, otherwise as well.
Okay, yes. So regarding anemia, is that, yes, anemia have to be looked up into two ways. One is the anemia related to the disease and per se renal cancer. One of the presentations of renal cancer may be just anemia. Okay, that you come, you are fatty, you are panicked, you are very tired, you look, and it is per se a presentation of the cancer. And as the cancer advances, you might have more grade 3 pallor and anemia. Next is the other anemia is related to the use of TKIs and the therapies and related to treatment. Okay, so yes, it has to be handled in a little different way. Once you treat the tumor and the tumor becomes tumor-related, anemia gets covered and also related. So what we do over here, divide anemia into, depending upon hemoglobin, into different categories on the trust. Now, like if you have quite a low hemoglobin, say about less than 7.5 grams per deciliter, definitely you will need a transfusion at least 1 to 2 units to put you back into around 8 to 9 grams, and that's a little comfortable hemoglobin where your quality of life will be a little better. Yes, if you have a hemoglobin ranging from 9 to 11 and still some sort of tiredness, weakness is there, yes, we do have drugs for like erythropoietin, which is erythropoietin stimulating drugs, and it's quite well played with the kidney cancers. With this, this is also altered. Yes, you can give darbepoetin, erythropoietin, and that helps. And the range is between 9 to 11 to make it up another, to make it to 13 and 14. Now, there is an in-between group which ranges between 9 and 10, which might, yes, in fact, all anemias needs to investigate it as per protocol. That is, you need to see there is iron deficiency anemia, megaloblastic anemia, macrocytic, microcytic deficiency anemias. That goes without, where we do the MCH, reticulocyte count, we see the peripheral smear, and also supplement. Vitamin supplement is important, B and 12, iron supplement, folic acid supplement. And this particular group, the middle group, which has a hemoglobin between 8 to 9, 10, there is, and even 9, 11, there is an also an therapeutic option of iron injection. It's iron sucrose. Many of our patients, we do give intravenous iron, elemental iron, to increase the hemoglobin. Okay, so we need to just cannot fully categorize them together. Yes, depending upon the causes, what are the underlying other factors, yes, treatment has to be individualized. But one thing, Aparna, I want to add, when we have treatment, these TKIs, and we all immunotherapy, these, we need to also counsel the patient that there is a side effect and you are to be aware of it and you need to cope up with it because everything cannot be treated. And that's what helps the patient. A little bit of discussion, a little bit of bringing them together. Yes, you have, and that gives them little confidence. And then, okay, you need to also adjust with it. All the anemia cannot be corrected. Yes, some can be.
Right. Yeah. I think the key thing that we find is that they are not sure, what is acceptable and what's not, and what they should go back to a doctor and discuss and what they should not. So I think that's often a issue that families struggle with. Dr. Gupta, again, coming back to you on hematuria, right? You said there are multiple types of hematuria. But again, how can these be managed, and, are they all treatable, or are there some cases where it's not really treatable? And what should patients and their families be aware of? Again, in the context of complications and side effects. Yeah.
Aparna, I clearly mentioned there are two types of hematuria in a kidney tumor. One you can see and one you cannot see, and see only in the microscope. When you can see the blood in the microscope, then we can say it's a microscopic hematuria.
Right.
And patients slowly have an anemia, which Anita has already discussed with you. One of the reasons of presentation of kidney tumor. Second thing is a gross hematuria, when patient and patient families is panicky to see the blood in the urine.
Right.
And if they see a continuous flow of a blood in the urine, they are always panicky. They want an urgent treatment.
Right.
There are two things, whether this is due to some blood-related reason or disease-related reason. If due to some blood-related reason or patient is taking some anticoagulant, then stop the anticoagulant for time being, and go for a conservative treatment as per the blood reports, like prothrombin times and platelets and other reasons. Correct then if there is a blood-related reason for bleeding with disease. If it's disease-induced hematuria, as doctor clearly mentioned about that, we should go for a surgery if possible in all the condition, and surgery is the treatment of choice for frank hematuria patients. But if patient is not fit for a surgery due to any reason, then you can go for an interventional radiologist help and go for embolization if possible at a particular site. And if not possible, then I would like to take an opinion of my radiation oncologist for hemostatic RT. If they can deliver the hemostatic RT despite of a less response as compared to other tumor in hemostatic site, I prefer fourth one is a hemostatic RT by radiation oncologist. When surgery is not possible, embolization or intervention radiologist cannot do or stop the bleeding, or conservative management fail, then I would like to go for hemostatic RT in such patients.
Right. Dr. Jayakumar, would you like to add anything to that?
Yes, yeah. But hemostatic RT to the kidney has, I have not so far given, because otherwise our surgeons used to help me. But hemostatic RT is one situation where as Dr. Gupta said, when all your armamentary fails, this is something which we can try. Because most of the time you can give away the hematuria with surgery.
Right.
That part.
Right. Okay. And doctor, and also for pain, what is the role of pain and palliation? What is the role of radiation?
Yeah. Radiation in kidney tumors is mainly for palliation and pain relief. Because as previous speakers said, these are highly metastatic potential. And one of the commonest sites of metastasis is the bone. And bone pain is one which is which can be controlled with our radiation. Newer techniques of radiation will definitely help pain relief. Similarly, other indication for radiation is the brain secondaries, which is also quite common. If you have a single solitary metastasis, you can go for the new modality of radiation like stereotactic SBRT or SRT. Or if you have multiple metastasis, you can go for a whole brain radiation. But and many times patient will come with disease in the pelvis, that time they will have severe pain and difficulty. So that time also again radiation is of excellent help. Otherwise, radiotherapy has not much role in kidney tumors.
Right. Thank you. Dr. Chatterjee, we've had some patients talk about swelling as well. Is that one of the common issues? And if so, how do you manage that?
Yeah, swelling can be of different causes. First of all, renal cancer is very having potential of deep venous thrombosis.
Right.
So there is blood clots in the lower limb veins, and that may cause limb swelling, usually present with unilateral, that is one side of the limb is swollen. So if that kind of swelling presents, we need to go for a Doppler study to find out if any venous thrombosis is present or not. If it is present, then anti-blood clotting drugs we use, like enoxaparin, to get the clot lysed. Otherwise, there may be generalized body swelling due to inherent kidney failure, because renal patients many of them are living with a single kidney, something like that, after surgery. And if this single kidney also get affected by diseases like diabetes, any kind of CKD, they may go on to end-stage renal disease and may present with whole body swelling. This is one of the cause. And there may be, again, treatment related, like like immunotherapy or this anti-VEGF therapy. If they present with body swelling, that is usually it is very dangerous. We need to look out the causes. If there is cardiac function is okay, if there is excessive edema present due to rash, grade 3-4 rash present or not, like that. But mostly we get patients with deep venous thrombosis with a single limb swelling, and then we treat it according to the way I've discussed.
Thank you. Dr. Gupta, is weight loss and cachexia and loss of appetite typically only in metastatic kidney cancer, or do you see that in earlier stage kidney cancer as well? And again, how should families manage that?
Means if you see the early stage kidney cancers are routinely seen by the urologist and incidental finding, and they are doing the surgery, means whether it's a partial nephrectomy or a nerve sparing nephrectomy or a radical nephrectomy.
Correct.
You know that the treatment of medical oncologists is started in a metastatic disease only.
Right.
And whenever there is a metastatic disease, patient is symptomatic. Means patient is having all the features I have already discussed with you. And weight loss as well as cachexia is one of the reasons. It's due to disease also, and it's due to treatment related complications also. Because sometimes there is a cytokines released in the body, and there is a wasting of the muscles and the skeletal system, and patient is having mucositis, diarrhea, sometimes ulceration in the mouth, the hemoglobin is low, they are feeling weight loss and as well as cachexia. So you identify the reason, number one. If there is a depression, motivate this patient for yoga, meditations, and with some medicine. Because cancer patients at one stage definitely has a features of depression, whether they are telling you or not telling you. Even the family sometimes basically feel that for a long time we are taking treatment, and so many financial aspects are also important, and one of the reasons of depression. Second thing, due to treatment, sometimes there is a loss of appetite, which leads to imbalance in the vitamins, even in the proteins. There is a hypoalbuminemia. There is a hemoglobin low because of the iron intake is less because of the mucositis, ulcer, vitamins are not taking properly. Patient is having a treatment-related complication as well as disease-related complication, and that's why patient is having a loss of weight and cachexia in number of metastatic disease of kidney tumor.
Right. Thank you. And yeah, we did do a interview on our website on cachexia, and it is also very psychological, as Dr. Gupta said. So you do need to handle that situation. If you're a family member, handle that situation carefully. You can't just force the patient to eat, right? So that doesn't work. So be aware that it is often psychological impact as well. Dr. Anita, are there any lifestyle changes that patients should be following while they are going through treatment, or after the first early incidence of kidney cancer? Any changes in diet, exercise, etc.?
Yes, lifestyle related things holds good, and I think it falls common for all cancers. Might told separately, yes, definitely for kidney cancer, we advise our people just first very thing, if you have comorbidities, please do consult your physician, and it may be a little more regularly, so that your hypertension, diabetes, thyroid problem, or any other neurological other problem is under control. That's one of them.
Right.
Definitely an 8-hour sleep is we advise. Good quantity of water, but depending upon your output of the urine, yes. And a kidney cancer, we always take a consultation with a nephrologist. It is always better to get their guidance and go, particularly when we have removed a kidney, okay, or you are having a CKD, okay. So these are the basic things. We advise them, please go meet them and come. Yes, we ask to take them lots of vegetables, maybe fruits. Some of the fruits and vegetables might be our contraindication, like coconut water, more of potassium, please avoid. So these type of, but more of green and multiple vegetables, and that's what the WHO says, 7 colorful vegetables and 7 colorful fruits. Okay, decrease the quantity of the carbs, anyhow, that holds good for everybody. Sugar content, less of salt, less of carbohydrate, and less of your spices is how it has to go. Yes, you need all freshly prepared food. And I always tell my patients, don't take the full meal, because you'll not be able to finish it during your treatment. We split it up into multiple diets, maybe 6 times a day is what you can have. And also on the psychological point of view, we do tell to have your whatever you like. Yes, that will be a better thing if you can eat what you want to eat. We also tell them to avoid smoking during this time. Don't smoke. To restrict your intake of the alcohol if you're taking, or don't take alcohol. That will be better. And regarding red meat, definitely not, because alcohol, tobacco, red meat are all under the same umbrella of very high rates to multiple comorbidities. Yes, white meat we do allow, because people will ask about non-vegetarian food. Yes, right, like chicken, but it should be cooked at home, non-spicy, less of salt, and maybe a grilled along with the vegetable is what the Western diet has. It should be a better option, but it should be cooked at home. That's what we tell them. Sometimes our dietitian, depends upon which place I'm working, does have recipes to make these foods, what I have told you, into a better palatable and more gooder option. So that makes the food little much better. That these are things we do put them up into dietitians, but because clinicians may not get a time to tell so many things, we do have a written thing which we handed over to the patients. Yes, kindly follow. Right. Another thing, Aparna, we do tell them to do yoga, but it can't be the biggest yogas and all. You can have online yoga consultation, yoga that fits your body, keeps the blood circulation, and meditation is again another aspect which gets already incorporated in the yoga. It makes you feel good. It increases the circulation, it increases immune power, and that also keeps you going.
Right.
And lastly, one point, immune booster, I also do in my TV programs. Yes, it's a common question asked everywhere. Do you need to eat anything which is natural to boost your immunity? Yes, there are 10 to 12 ingredients. One is lemon, one is tea, green tea, one is ginger, one clove, dalchini, turmeric. Turmeric has a huge amount of antioxidants in them, and these are some of the other things. So many, all those cardamom and everything adds to the ginger. Okay, so when we add all of them together, they all add to the immune booster. Only it prevents you from the getting the side effects less in a cancer, but it also fights you the COVID. And these discussions keep coming on with the COVID pandemic around with the treatment of cancer. So a little bit of holistic approach. Yes, the clinician need to spend some time to give them, but then we do put them up into physicians also, dietitians also, which will take them through. That's what I feel we can tell them for lifestyle related behaviors.
Thank you. Thank you, Dr. Anita, for the comprehensive response. Dr. Gupta, kidney cancer also has a genetic component, right? So for those who have a family history or at higher risk, what are the options available for them to manage their concerns or to be vigilant? What is advised to them?
Actually, Aparna, you can see that there are 6-7 syndromes are associated with kidney tumors.
Right.
And every tumor is having a specific presentation. I'm just giving an advice to all my patients that if there is a family history of a cancer is first degree relatives, second degree relatives, always check the age, at what age your parents or your relative had a disease.
Right.
And 10 years prior to that, always go for a screening methods.
Right.
If you see 6 to 7 syndrome, every syndrome is having a specific age and year of basically screening methods. In few, you can go for 8 to 10 years at the age if there is a family history. Few they mention about 10 to 15 years, and few they mention about 30 years of age of screening by the CT or by the MRI of the abdomen, and going for a screening 3 yearly and later on 5 yearly. The important thing is that only 3 to 4% patient of kidney tumors are having a familial hereditary syndrome associated disease. Not much number. It's only 3 to 4%.
Right.
And in India, if you see in total, this is only 3.9% patients are having an incidence of the kidney tumor as per the Globocon 2021.
Right. Right.
And basically, you can see that sporadic cases are more. Means you can say 90 to 90% patients are sporadic in the sense because they are having a history of hypertension, obesity, alcohol, tobacco in any form, chemicals, drug, even the aspirin and the NSAIDs in prolonged use causing the kidney tumor, polycystic disease. These are the sporadic cases are more common as compared to hereditary cancer in India. Right. It's only 3 to 4% in India.
Okay. Thank you. Thank you, Dr. Gupta. Dr. Chatterjee, we have actually one more question that's come in as well. For the renal cancer survivors, they often struggle with the lower back pain. What can they do to manage that pain?
Lower back pain may not be as such common to the only for the kidney tumor patients. It is to be managed precisely like any other lower back pain. If the pain is really significant, causing problems, you need to see your doctor because we always fear the bone metastasis. Bone metastasis is one of the commonest site of bone metastasis is the lower vertebrae. Upper lumbar, lower thoracic vertebrae. So the back pain you should not ignore in a renal cancer survivor patient who has undergone, say, a kidney tumor 4-5 years back, and just ignore a back pain is not like any other cause of back pain. You should see your doctor and rule out if there is a bony metastasis or not. That is the most important thing. And otherwise, when there is not a cause is ascertained, you then go for according to the cause. You need to get your treatment like physiotherapy, diet, medicines, weight reduction like that. But one thing you need to remember that bone metastasis is one of the dreaded complication or dreaded cause of low back pain in a renal cancer survivor patient.
So talking of the follow-up, and also, sorry, one question before that, is osteoporosis a common kind of post-treatment effect of early stage, not metastatic, but early stage kidney cancer?
Osteoporosis is not related with the not
okay.
Related.
All right.
Any cause of osteoporosis is very common in our country.
I know.
Because
I know. But there are certain cancers where osteoporosis because of hormonal
osteoporosis
therapy
may happen in a breast cancer survivor.
Correct. So we just want to make sure that
they take a lot of drugs which cause reduction in the bone density, but not as such in case of kidney cancer survivors.
Okay, thank you. And how often should the follow-up with the specialist be, and what they should? You mentioned that they should be careful about. bone metastasis because of the pain, but what else should they be watchful for recurrence?
Yeah, I tell them about the few warning signs in case of kidney cancer or say any other cancer. First of all, bone pain. Bone pain, which is not relieved by normal medications, it is increasing in intensity and increasing in movement, and so that its severity is very high. So that if you just touch the area, there is a lot of pain. This kind of bone pain should not be ignored. Certainly, you have to go to your physician. Then chronic cough. That can be one of the symptom of a dreaded lung metastasis. Chronic cough for a long time, persisting more than 15 days, 1 month, and not relieved with normal medications. You should not ignore. These kind of complications can happen. And then renal cancer is also very notorious for brain mets. Sometimes a patient present with early morning headache, nausea, vomiting, continuous throbbing headache. That should not be ignored like our normal cause of a headache, and you need to rule out if there is any metastasis. Or in the early months of early years of the follow-up after surgery, we call the patient for at least in every 3 months, and we take their complete blood counts, renal function test, liver function test, lactate dehydrogenase to see if there is any indication of any metastasis, like increase in the alkaline phosphatase, which may indicate about a bone metastasis, sudden fall in hemoglobin, we have a sudden rise in value of lactate dehydrogenase. Then we think if there is any metastasis or not. And routine scanning, actually I go for a routine CT, thorax and whole abdomen every year, once a year, and every 6 months I subject the patients to a ultrasound abdomen and thoracic X-ray, and this is my follow-up guideline. In first 3 years, there comes about in every 3 months. Then the follow-up duration increases. In fourth year, about 4 months, and then 6 monthly, and then yearly. But with these warning signs, you need to come in between.
Okay, thank you, Dr. Chatterjee. Dr. Jayakumar, one question, because once patients enter what is now called cancer land, I think Dr. Siddharth Mukherjee used that term, they're constantly stressed and anxious, right? So if they've ever been diagnosed, you're constantly worried. What are the questions they should ask their treating doctor to kind of get a sense of, assurance, or so that they're not just kind of swimming in the dark?
Yeah, partly that was answered by Dr. Chatterjee.
Correct.
Yeah, that is there. But still, one thing we should tell the patient is it is a curable disease. It's a treatable disease. So nothing to panic. You do a normal life. And also they should be aware of they are having only one kidney. So renal toxic drugs has to be avoided. So whenever they go for treatment to any doctor, they should mention about their previous kidney disease, because otherwise the doctor may be prescribing nephrotoxic drugs, which is not good. So other thing is, as he said, as Dr. Chatterjee said, we should tell them about the sites of metastasis, and they should immediately report to the doctor at earlier stage, because still metastatic disease we can treat and cure. It has become a chronic disease with newer drugs and newer drugs. So reassurance to the patient is very important. Warning signs to the patient is very important. And their treating doctor, their family physician should also know about their disease. These are the common things which I talk to them. Otherwise, they can have a normal life, accepting that they have to avoid your certain type of food, as previously mentioned, alcohol, avoidance alcohol, and also smoking, cessation of smoking, etc., etc. These are the things which I usually tell to my patients. Yeah.
Okay, thank you, Dr. Jayakumar. Dr. Suvarna, a couple of questions, right? Because financial aspect of the treatment is always a big factor. So two questions. One is, what are the government kind of schemes or packages that are out there for, whether it's in PMJ, and I think some states may have as well. And second is, how is the industry supporting kidney cancer patients?
From a government perspective, the Ayushman Bharat Pradhan Mantri Jan Arogya Yojana, they do have a kind of a treatment package of, I think, about 5 lakhs per family. under which surgery and chemotherapy definitely is included. I'm not sure about radiotherapy or even medical therapy, like, what Dr. Gupta mentioned. And of course, as you said, in some states like Himachal Pradesh, I think they call it Him Care. Then there's the Biju Patnaik Yojana in Orissa, some Ma Yojana in Gujarat, and Swasthya Sathi in West Bengal. So those kind of packages are there. In terms of industry, so I mean, I've worked in the past even in companies which have come out with these innovator kind of medicines, and obviously these medicines are very expensive.
Right.
So then what the company tries to do is, one is, of course, if you're below the poverty line, it is given free of cost. For those who are not reimbursed but above the poverty line, then there is a assistance program. So sometimes it's like you purchase one strip and the next strip is free, or maybe 3 cycles or 4 cycles you pay for and then it's free for life. Or sometimes, if you're part of a clinical trial,
right,
and these clinical trials also have an open label extension phase where the patients continue to receive that medication for as long as they live, in the sense either till the cancer progresses or they just can't tolerate the medication. So these are some of the ways they kind of try to improve access, but I still feel that much more can and should be done. As far as Biocon is concerned, one is, of course, we do have a patient support program called ACE, which is all about assist, care, and educate. We obviously, I mean, based on the doctor telling us, then we would make the medication free. But in our case, for example, we launched Pazopanib, that is the generic Pazopanib. So obviously it'll be cheaper than Votrient. But, and then of course we are good at biosimilars. So with biosimilars, again, you do reduce the price, but the quality is world-class and even the approvals are in major markets. So to that extent, obviously, you're again allowing more patients to access the medication. If at all we come out with our own novel, and we do have at least one in cancer, actually more than one, but there what happens is, again, we try our level best to lower the cost, but clearly with cancer, and this is what I remember telling my earlier company, that you must actually lower the cost. See, what happens is, I agree that people, they'll do anything to, get that particular medication, and that should not be taken as something that you can, command a higher price. In fact, because of the fact that the financial toxicity actually pushes people below the poverty line, in cancer, I feel one must lower the price, no matter what the innovation or whatever we may talk about, because it's quite sad to see what happens to families when, I'm just thinking, if I get cancer, will I actually want my family to go under the, below the poverty line? I would
that's
rather
a huge
that,
issue that a lot of families face with cancer treatment. I'm just conscious of the time, Dr. Suvarna. Any closing comments from the panel, Dr. Gupta?
Means if you see the kidney cancer, which was initially people thought it's the end of roads, I say it's not the end of roads.
Right.
The new drugs are available. Not only one drug, multiple drugs are available. We have not only the radical surgery by the open laparotomy, we are having a robotic surgery in Delhi and in metro cities. We are having cosmetic surgery as well as. So it's not the end of roads. The triads of kidney tumors is hematuria, flank pain, and mass is the features. But rarely you can see varicose vein in the males. If any patient who is having a varicocele or a varicose vein and have a lump in the kidney side or microscopic hematuria, always search for renal cell carcinoma, because this is a incidental finding most of the time in the ultrasound. So I can say to the public that it's not the end of roads. The new drugs are available. You must have a hope. There is no need for any depression. We have a curative intent in the early stage disease. Even in a metastatic disease, we have a quality of life and maximum survival.
Right. Thank you, Dr. Gupta. Dr. Jayakumar, any final closing?
Yeah, same as that. No, it is not the end of life. Kidney tumor has become a chronic disease. We have a lot of newer drugs available. lot of newer treatments are available. So as and when they develop newer metastasis or this thing, again, we can continue the treatment and make the life quality of life good.
Right. Dr. Anita?
Yes, Aparna, you want me to speak?
Yeah, just any closing comments?
Okay. A closing comment, one sentence. I think that is also the this year's motto or the slogan for the World Cancer Day on 4th of Feb, bridge the gap.
Right.
That's what we are looking at, bridge the gap. Many of these medicines are exorbitantly expensive. I work in a medical college setting as well as in the private sector. So when I'm in the medical college with whatever Ayushman Bharat, the Tamil Nadu chief ministers, the approval per patient for the drug is not more than 5,000-6,000 rupees. Okay, and it never goes up to 10,000 rupees. So we cannot discuss about all this, what we spoke today, giving immunotherapies, TKIs. I told so many things to be given. That's only anything which is cheaper than 6,000 or 7,000 rupees can be given. We do have sorafenib. And thanks to Biocon, and I think there are 2 more companies which have already come with the pazopanib before this. So we have started using pazopanib, sorafenib, and 1 company has come with the generic sunitinib. So that's all we can give to 70% of the Indian population. So there's a big gap in the treatment. Rest,
Right.
immunotherapy, TKIs is only for 5%, maximum 10% of a diagnosed renal cell cancer. So in India, a big gap exists, and our motive at this point of time is how we bridge the gap. And I welcome companies like Biocon coming in with more generics, but the cost has to be really cheap because the treatment continues till you progress. So, so to make it more affordable care for the needy.
Right. Thank you, Dr. Anita. Dr. Chatterjee?
I would like to say kidney cancer is a good type of malignancy. Most of the patients get cured. If you find anything, incidental findings for the routine ultrasound scan for any other cause, if there is a chance of a renal tumor, get a good quality CT scan done and then straight go for a surgery. We don't always go for a biopsy for a kidney tumor. That is not recommended. With the scan findings suggestive of a malignancy, you should go for a surgery. And with surgery, most of the patient get cured. So nothing to worry about kidney cancer. Stop your smoking. So that didn't develop. Most of our patients are having smoking or tobacco related kidney cancers. Kidney cancer is a good type of tumor. Early treatment will give you cure.
Right. Thank you, Dr. Chatterjee. Thank you to all our panelists for taking the time. And I think, as they all said, kidney cancer, the treatment has progressed a lot over the last few decades. So don't lose hope, but do understand the treatment, do understand your complications, do discuss the options with your treating physicians, and be aware of the symptoms and the side effects and monitor well for recurrence. Yes, and I think at a larger scale, we do need to do much more to bridge and close the care gap. And that's something that we will have to continue. So thank you, Dr. Gupta, Dr. Jayakumar, Dr. Chatterjee, and Dr. Suvarna, and thank you, Biocon, for supporting this patient education initiative. And thank you to all our viewers who've been watching this and also sending us questions. And if you ever have any questions, you can write into us, and we will make sure that it gets answered. Thank you, everyone.
Thank you,
Thank you very much.
Arpana, thank you, Biocon.
Thank you.
Thank you.
Thank you, Dr. Gupta. Thank you, Dr. Jayakumar.